Hello, everyone. This is Dr. Susan Hudson with another episode with Fertility Docs Uncensored. And I have my amazing, delightful, brainiac co-host, Dr. Carrie Bedient from Fertility Center of Las Vegas.
Hi.
And Dr. Eblen from Nashville Fertility Center.
Hi.
How are y'all doing today?
Oh my God, I'm not awake.
Carrie's a little sleepy. Her high was not really like cheery the way it normally is. We made her roll out of bed early this morning.
I will be fully awake within the next few minutes, but I am counting on the tea my husband is bringing me.
All good. All good. So what have you guys been up to lately?
So my husband just took a golf trip, and the Masters tournament was pretty recently.
Oh, yes.
Oh, wow.
Yes.
And
did he go? He went to the Masters?
He went to the Masters.
Ooh.
And the way that you get in is there's a lottery. So like I have been putting our names in for years since we lived in Atlanta for fellowship, because my husband likes to golf and I think it's watching grass grow, but I love my husband. And so I've been doing this kind of behind the scenes for years. So
oh, wow.
I didn't win it, but our brother-in-law did. And so he and my father-in-law and my husband and my sister all went to one of the practice rounds. So they all got separated at one point because my father-in-law wandered off, essentially. So 5 hours later, they found him. But in the process of looking for them, my husband, who's an intensive care doc, was walking along one of the paths and somebody dropped right in front of him.
Oh, no.
And so he and a couple other bystanders like immediately started CPR. They're well staffed. They had paramedics on the scene within like 5-10 minutes. And the guy got circulation back. So it's a happy ending.
Awesome.
But so my question for you guys is, have you ever been the doc out in the world, on the plane, at the festival, at the event, whatever? Have you ever been the doc out in the world?
I have on a plane, and I can say, I would much rather be your husband, who's an intensive care specialist.
I know.
Be an OB-GYN who specializes in fertility when these things happen. But it's amazing how things that you haven't thought about in like 15, maybe 20 years can like kick back in when you're in that situation.
Oh,
it
yeah.
actually happened to me on a plane for the first time, probably about a year and a half ago. And there was a gentleman just in the seat behind me who had a lot of anxiety about flying, and he had taken a whole lot of medications, including like anti-motion sickness medicines, as well as Benadryl. And I think there was something else added into that cocktail. And essentially he started having a dystonic reaction. And for our listeners, that's where essentially your body completely contorts and you can't move. And it's a very awkward looking, and it is, I am sure, a very awkward feeling type of situation.
Oh, yeah.
And I had to go and help him. And fortunately, it started reversing itself pretty quickly and stuff. But yes, that was my experience, because I haven't thought about dystonic reactions since probably I was in medical school.
No, not at all.
Holy cow.
Yeah, but if you're ever on that situation on plane, always remember there are actually docs on the ground that the airlines can communicate with you. So, if it's something outside of your realm of comfort and everything like that, that you really can phone a friend.
So my med school in Phoenix, they had one of those setups. And so when I was doing my emergency room rotations or traveling through when I was on a visiting service, there would be this room that you would walk by, and it was a huge long room, and there were flight plans everywhere up on the ceilings, and there were just like where people were calling from, and it looked like a call center that was it was a combination between a call center and in the movies how they depict the NASA control room.
Yes.
Yeah.
That's what it looked like.
And there were
I, of
people like
course,
in there, like there were actually people, and that's all they did all day was answer phone
yes,
calls.
Mhm.
No
yes, it was part
kidding.
of the ED doc's
That's
responsibilities.
really nice.
Oh,
That's really
yeah,
nice.
that is. I
Yeah,
didn't know that.
yeah.
Well, my only experience was I was coming back from Thanksgiving weekend at with my family, and I was halfway between Knoxville and Nashville, kind of on a somewhat deserted area of the road, and I saw all these people running down. The highway was kind of divided, and I was a little bit on the lower side, and the other two lanes were on the upper side. People were running down this hill, and I'm like, what is going on? And all of a sudden, I see this man just laying there, kind of splattered out or splayed out, I guess, with no shirt on, and people were running toward him. And I'm like, oh my gosh, something must have just happened. And because we have a surgery center connected to our office legally, every 2 years we have to take ACLS, advanced cardiac life support.
Mhm.
And so we do that every 2 years. In fact, I just took it about a month and a half ago. And the good
I'm
thing
taking it
about
the next month too. Yep,
yeah,
same
the
thing.
good thing about it is if you take it, every 2 years, finally things finally start to stick, and you kind of get those, those protocols in your head. And so I thought, well, I was a little scared myself because, like Susan said, I'm a OBGYN, I'm a fertility doctor, but I can do CPR. And really, I think when you're on the side of the road or really up in a plane, there's probably not a lot you have that you can really do other than CPR or give them oxygen or something like that. So we did. So we started CPR, and it was myself and a nurse and I think a school teacher, I think. And so we just started doing chest compressions. And now for people who don't know, you don't have to do mouth to mouth. You just do really good chest compressions to help them suck in ambient air. And so you don't have to give mouth to mouth. So there's no reason that you wouldn't want to stop and help if you know how to do chest compressions. And so we did, and we did chest compressions until an ambulance got there, and then they, loaded him up. I don't know if he made it or not. I don't know what the outcome was, but he did have some pretty significant injuries. So I kind of doubt it, but at least we felt like we did our part, and that made me feel good. At least I tried.
Yeah.
Carrie, have you?
When I was in residency and I had been in residency for like a week at this point, so I'm nothing more than a glorified medical student. My husband and I and a bunch of friends had gone to this wine tasting festival in nowhere, Ohio. And so it's me as an OBGYN, the only adult doctor in the group because everyone else was a pediatrician. And this woman drops and somebody goes, she's having a seizure. And my husband looks at me and he goes, and he points and he goes, she's a doctor.
She's a female doctor.
And so I walk over because I was an EMT in college. And so, like you said,
Okay.
a lot of those things are just
Yeah.
ingrained, like, the ABCD,
The
the
protocols. Yeah.
OPQRST, like all of that is so deep within my brain that I just started going
It just
that.
pops
And
up and you start
Chest
doing
compressions for 2 minutes.
and she fortunately had just had too much to drink is really what it amounted to. But that story has lived on in lore in our family because now whenever anything happens, I look at him and go, he's a doctor. And, and so that has been a long-standing story, and that story's not going anywhere. Like I fully intend for the next 20 years, if ever anything happens, because he's an intensivist now.
Yeah.
He's a
Very
doctor.
handy to have around. Yeah. For anybody.
Yeah. Like I can talk anybody off a ledge, but
You could deliver a baby. If somebody was delivering a baby on the side of the road, you'd be the one.
true story.
True.
True story. I keep looking every time I go on a plane, I'm looking around.
I always eyeball the pregnant women.
Well, we're going on a flight to Europe this summer, and I usually don't ever put the MD or the doctor in front of my name, but somebody else did it for me, and I'm like, I just noticed, I'm like, oh, I'm Dr. Abby Eblen on the plane. I'm like, oh,
It's all good.
I have some friends that have stories about where they basically said, should we turn the plane around and go back, or should we keep going?
That's the major decision making thing.
Yeah, that's scary. So I'm glad there's a control center.
Let's start moving on. So let's have our question of the day. So our question is, what to do if you overstimulate on Clomid? My husband and I attempted IUI 3 times, but were only able to inseminate on month 3 with no Clomid and only trigger shot. I am 34 and we are giving our all this year until we turn to IVF. Would letrozole be a better option to prevent this from happening? I am not opposed to multiples, but even 25 milligrams of Clomid was producing 4 follicles. How to prevent that from happening and wasting a cycle and money on ultrasounds? Thank you.
So bottom line is Clomid has a long half-life and it can hang out in your system for up to 6 weeks after the last pill. Some people just don't do well on Clomid, and you're one of them. The problem with oral medicine, because they have such a long half-life, we really can't control how you stimulate very well. Sorry, I have a frog in my throat. We can't control how you stimulate very well. I would try letrozole. I think your chances are a little bit lower. You would still say there's about the same risk of multiples, but I think people, in my experience, tend to do better. The half-life is 48 hours, shorter half-life. I think you should start out on the lowest dose, and I do think there's a good chance you do well with that.
What about Carrie?
Yeah, I like the letrozole idea. You know, using the oral meds does help you pin down the timing a little bit better. The thing that we always worry about when someone's not on any meds and we're just waiting for a trigger shot is, are you going to ovulate prematurely? Is an ovulation predictor kit going to pick it up? Because for a lot of our patients, they don't really work. That's why there are patients. And so that's why we tend to favor these meds. I use Clomid, but very rarely. Like letrozole is my go-to. It is the ovulation induction agent of choice because people tolerate it pretty well, and you don't get overstimulation nearly as much, and there's no chance of hyperstimulation or extraordinarily rarely. And so,
well, every now and then people can hyperstimulate letrozole.
I mean,
it's rarer than on Clomid. I mean, I agree with that. Letrozole is my go-to oral stimulant. The only people I use Clomid on are people who honestly have gotten pregnant on Clomid before and insist on using it again.
Exactly.
I'm like, that or guys.
Well,
yeah, or if someone's resistant to letrozole, like some of the PCOS patients, about 15% are resistant to all the oral meds. And so we usually go through quite a few. There was an article that looked at combination of letrozole and Clomid, particularly in PCOS patients who were resistant, not as a starting MO, but who were resistant, that it was beneficial. But yeah, it's rare that I actually use Clomid unless someone says, I must have Clomid.
Yeah, the other really amazing thing, having used Clomid for a lot of my career and then using letrozole, it really is amazing the difference in side effects. I mean, people will ask me every now and then, because I'll forget to say anything about side effects, and they'll be like, well, what are the side effects? I'm like, well, really, there's not a lot. I mean, and in fact, ironically, the drug that most people complain about the most in terms of side effects is Clomid. So yeah, I try and avoid it as best I can, because it's just doesn't work as well and has a lot more problems associated with it.
Good stuff. Good stuff. All right. So we're going to move on to our topic of the day. And what we're going to talk about is, you know, we all have those patients who come in and they're like, I just want to have one baby. You know, they're just focused on like right here and now. But we also have patients who come in who are like, you know, I really want to have multiple children. You know, I want to have 2, 3, 4 children over the course of my reproductive life. I'm struggling here and now, but I want to keep in mind that I want to have this, you know, family of more than one. And so what we're going to talk about are things to think about and options that are available if you're really wanting to do this type of family planning in light of having fertility challenges. So, Carrie, what are some of the first things you should think about yourself when you're thinking about having multiple children over your reproductive life in light of infertility?
So one of the things that I always ask people is how many children do you want to have? Knowing that I will not hold you to this answer, you are fully entitled to change your mind, because I have a lot of people who come in saying, I want 5. And then after 2, they're like, no, good. But one of the things is what's the general range you want? Because most people, even if they don't know the exact number, they know like, yeah, I'm a 1, maybe 2, or I'm a 1, maybe 0, versus I'm a 2 and would veer towards 3 or 4 rather than down to 1. And so knowing that distinction within yourself is helpful. Now, oftentimes, and I'm sure you ladies have seen this, you ask that question and the one partner gives one answer.
Yeah.
And then the other one gives a drastically different answer. Yeah. And so that's part of the reason why I always say I will not hold you to this. And we tend to go with whatever requires more planning. Like if somebody wants half a child and the other one wants 5, we're going to veer towards, okay, we need to at least have the option of more than one here. And of course, the couple gets final say. We're not going to talk anybody into anything, because you cannot talk someone into having a child.
No.
Like, not, or I suppose you could. We don't do stuff like that because no,
It's a personal
just
choice.
no.
Yeah.
There's too much that goes into that in so many forms, but really having a good idea of where you fall is huge, because and I keep seeing this a lot, unless you know what you want, you can't get there.
Right.
And so you have to know what you want, because I'm going to recommend different things if you say, maybe one versus a whole bunch.
Abby, what's another major factor that we take in consideration when balancing that number out in our brains?
Well, if you think, to get ready to have a baby, to have, to be pregnant for 9 months, then deliver the baby, maybe breastfeed the baby for a year, best case scenario, you're looking at probably 2 years between each pregnancy, and we really feel like it's healthy once you've gotten pregnant to wait at least a year before you have another baby. There's some studies that show there can be, some complications with the pregnancy if you do it a little bit quicker than that. And I think American College of OBGYN actually recommends waiting a year in between pregnancies. So the big factor that we think a lot about is time. And so if you're telling me today that you want to have 4 or 5 babies, you're looking at 8 or 10 years maybe. So, that's important. And the difference between you now and you in 5 or 6 years and your egg quality in 5 or 6 years can be really huge. So I think that really weighs heavily on what we recommend, based on the number of embryos that you or number of babies you want to have.
And I think the big thing here that we're really kind of hitting is that, what is your starting age at this point? If you're coming to us and you're 25 and you want to have 3 or 4 kids, versus you're coming to me and you're 35 and you want to have 3 or 4 kids, those take some different levels of planning and understanding kind of what happens with age and what happens over time. So kind of to hit on that a little bit, can we review what happens? Why is age in women such a big deal?
So in the process of writing all my med student lectures that go over all of this, so the reason age is such a big deal is because at this point, the volume of oocytes or eggs is fixed. So the peak that they have is 6 to 7 million when you're about like halfway through pregnancy, before you even come out into the world. At the time that you hit delivery, females have about 1 to 2 million eggs. By the time you hit puberty, it's about 300 to 500,000. By the time you hit menopause, it's a couple hundred to 1,000. So note that I'm saying at menopause, you still have several hundred eggs. So it's not like they fall down to 0, but the quality of those eggs decreases, because if you imagine the state of your car when it was brand new versus the state of a car 40 years later, they are 2 different things. Doesn't mean it doesn't run, doesn't mean it can't get you to your destination, but you are going to have to think a lot harder about the care and maintenance along the way in order to make sure you truly get to your destination and not on a stretcher and not pushing the car. And so that's where the baseline is. Now, throughout the course of time, there is decrease in the number of eggs because you have a cohort of follicles that are being released every single month. This is true whether or not you're getting infertility treatment. So
describe what you mean by cohort of follicles.
So when you have, when you do an ultrasound, for example, at the beginning of the cycle, when we're looking for an antral follicle count, what we are looking for is the approximate number of follicles that are starting to grow. So
and follicles are
the itty bitty teeny tiny baby eggs. And they have the ability to grow into a mature egg, which is what our goal is. But most of them aren't going to make it in a natural cycle. So if someone is in their, let's say, early 20s, they're easily going to have 20 follicles that are starting to grow. Only one is going to get the support to make it and ovulate, and all the rest are going to die off. And that is normal and expected. By the time you get to 40, your body is not going to be quite so flippant with the number of eggs that it is releasing. It's going to release maybe 5 instead of 20. And so you have far fewer to choose from. And so when I think of it in terms of what are you getting when you reach into the grab bag, if you go to the grocery store at 9 a.m. on a Saturday morning, right after they've restocked, and you grab for an apple, Doesn't matter what apple you grab, it's going to be good. When you go at 10 p.m. on a Sunday night, before anything has come out, before they've restocked, before any of that, there's going to be apples there, but there's a lot of bruises.
The bad apples. I like that analogy, Carrie. I'm going to use that.
So as you go through life, the number of available eggs and the quality of those eggs is going to decrease. And so that's why we look at this so differently when someone comes in and they're 40 versus when they're 25, because we know that our starting baseline is different. And even if someone has an amazing number of apples there and their egg testing is great, those apples have still been sitting there and have been jostled and have been subject to whatever has gone through the grocery store in the last couple of days. And those are different apples than the ones that are fresh on a Saturday morning.
Well, and the other factor, and you kind of alluded to it, not only are the number of eggs decreasing, but when you say quality, what that means to me is that genetically the eggs are just not as good. So the difference between someone's egg if she's under the age of 35 and someone's egg if she's over the age of 35 are very different. And it's hard for patients to realize, and really for us as physicians to believe, except we do IVF all the time and see this, how different a 31-year-old is from a 39-year-old. Huge difference in egg number and egg quality. So big changes in your 30s, not so much in your 20s. But, when you're getting to the middle of your 30s, that's when all of a sudden your eggs, each month an egg is released. When it's released, all of a sudden it has to divide in two and kick out half of the chromosomes to make way for the sperm to swim in and create a baby that's a combination of you and your husband. And unfortunately, after age 35, that just doesn't happen so great. Those little, if you remember back to high school biology, those little fibers, spindle fibers that pull the chromosomes apart kind of break. And so a lot of times the eggs are genetically abnormal. We know even in the perfect world, if you're under 35, about half of the ovulations that you have create eggs that are genetically abnormal, meaning they don't have the right number of eggs. So you either don't get pregnant, or if the egg is fertilized, it could result in an early miscarriage. And so that's why even young women have miscarriages. But as you get older, the chances of that abnormal division of chromosomes is much more likely. And somewhere around 40, it's like 90% of the eggs that you produce are genetically abnormal. So what that means is even if you get pregnant, about 40% chance of miscarriage at age 40, unfortunately, because of that.
So before we start getting into some options, let's talk a little bit about men, just because, they're the other half of the...
We do need them, don't we?
We do need them. We do need them. And I do kind of consider it, yes, men continue to produce sperm throughout their entire lives, but is that sperm quite as good as what it was when they were youngins?
Spry.
So when you look at sperm quality, just in the same way that anything that the woman has gone through in her life impacts the egg quality, anything that he has gone through in his life impacts sperm quality. And so a 50-year-old guy is far more likely to have done some things, whether that is smoking, whether that is drug use, whether that is alcohol, whether that is long-term hiking, testosterone. Oh my God, the testosterone. Guys,
exposure to STDs that can clog things up. STDs.
Yeah. All of those things can have happened. Vasectomies, vasectomy reversals, all that stuff. And so that's got a part of it. And then the other part is the genetic part. So because even though sperm is being made fresh, it's still reliant on a set of cells that have been there for a longer period of time. So as sperm ages, you get more what are called epigenetic changes. And so epigenetics is a little bit different than straight genetics. So the way that I think of it is you've got a bunch of light switches in a room, and genetic changes are when some of the light
wiring
switches
behind the light switches.
The wiring behind the light switches is just not good. The switch itself is broken, it's absent, it's cracked, whatever. Epigenetics is how those switches are turned on or turned off. So that can be wildly different. Like you can walk into a room that is blazing light. You can walk into a room that is pitch black, walk into a room that's got one little spotlight in a corner. All of those things can come from the exact same set of switches. So as men age and they're exposed to all of these things and just the normal aging process, the epigenetics change. And so you start to see more conditions like schizophrenia, like bipolar, like autism, all of those types of things because of the way the epigenetics, or those switches, change. And so even though it's not quite as dramatic with men, there's still changes happening. It's just they get a little bit more leeway than we do as women.
And there are a few sporadic autosomal dominant mutations that men can have as they age as well. So yeah, so things are not working perfectly with them, but they do tend to have good sperm
Yeah.
Absolutely.
for a
Unless they're on
while.
testosterone, don't take testosterone, boys.
Or
Not if you want.
or supplements that you get over the internet that you don't really know what they are. Don't take those either.
Yes. Pre-testosterone things are sometimes just as dangerous as testosterone. So,
Yeah.
all right. Well, let's talk about, so I'm a fertility patient and I'm wanting to have 2, 3, 4 children. What is an option that I might consider for planning for not only this pregnancy, but future pregnancies?
So the only way to really freeze your egg cells in time is to freeze your egg cells. So if you go through IVF and you freeze eggs, it's not, I mean, the realm of IVF cost wise, it's not as expensive as it would be if you went through the whole process and fertilized the egg. But one option would be just to keep those eggs on reserve, just to keep them. It's like kind of keeping meat frozen in the refrigerator. As long as you keep it frozen, when you thaw it out, it's really good. And same thing with your eggs. Your eggs are frozen in time. Your eggs are the same age as you are. And generally, our egg freezing techniques are such now that the eggs thaw out very well and do very well. And the younger you are when you freeze those eggs, the better they do when you thaw them out. So it's better to freeze your eggs at 30 as opposed to waiting to 35 or 39 to freeze your eggs, because young eggs do much, much better.
How many eggs should somebody freeze if they're thinking about a baby in the future?
So one of the, I want to say it was the Kobo studies, had at age 34. So the outcome here, it was in order to have 75% chance of a live birth. At age 34, you needed 10 mature eggs. At age 37, you needed 20 mature eggs. At age 42, you needed like 60 plus. I think it was 63, but it was well over 60.
Huge number.
You need a huge number. And the availability of those eggs is wildly different. Age 34, you can hit 10 eggs usually pretty easily because most women are going to have enough to get that. At age 37 to get 20, it's not just 2 cycles that you're going to need. It very well maybe 3 or 4 or more. By the time you hit age 42,
this is for one more baby. This is for one more baby.
And this is for one more baby. By the time you hit age 42 and you need 60 eggs, in an average 42-year-old, that's like 10 cycles easily.
If you're lucky. Yeah.
If you're lucky.
If you can make it through the cycle. Yeah.
So if somebody is in a situation that they know that they either have a committed partner that they are planning on having all of their children with, or decided they were going to do this with donor sperm, so they've got plenty of sperm, who do you recommend to do freezing eggs versus freezing embryos?
I mean, I think if you have a committed partner, you're pretty certain that he's the one and you're going to be together, and raise a family together. Or if you're, in your mid to late 30s, you may want to really seriously consider not just freezing your eggs, but putting the eggs and the sperm together. And the reason you may want to do that is we can just give a lot more information about prognosis. So if you had 10 frozen eggs, it's hard to predict how many are going to thaw, although most of them will probably thaw pretty well, but we don't know how they're going to fertilize. We don't know. I mean, it's really a crapshoot for a given person. You never know. Sometimes eggs thaw great. Sometimes we're shocked because not many thaw very well at all. So really, there's not a lot of prognostic information, and it could just stop right there. If the eggs don't freeze well and don't have good fertilization, you may be finished and not be able to continue on. The advantage of creating embryos is we know that if we have a genetically normal embryo, that gives you around a 60 to 65% chance of pregnancy, not just a pregnancy, but having a baby in your arms at the end of 9 months. The other advantage to doing that is, say on the flip side, you don't do very well. Say we we take these eggs out of you, we put them with sperm, and say we don't have any normal embryos. Then the nice thing is at that point, you have the option of starting all over again, which is, emotionally and physically and financially a lot to think about. But you have that option at that point to say, yeah, I really want to have a baby that's biologically my own. So I really want to do this again to freeze more eggs. there's a difference in doing that now versus, say, finding that out 5 or 6 years from now, because at that point you may not have the option to freeze eggs. You may be 42, 43, 44, and that door is already shut. So it just gives you more options if you freeze embryos, because you really have more of an idea about what's going to happen down the pike.
Carrie?
So there's some people who come in and they ask, can I freeze both eggs and embryos? Can I do a 50-50 split? And the answer is technically yes, we can do that. It's whether or not that serves you. Because if you have, if you're doing this at age 28 and you got 30 eggs, then most of us are going to be not think a whole lot about, yeah, well, we'll freeze 15, we'll make 15 into embryos, then you've got some banked if you ever need it, because a lot of life can change between 28 and when you decide you're done having kids. So that effectively ends up being a reasonable option. A lot of women, when they come in, they're like, well, I want to freeze eggs and I want to create embryos. Can I just do that in one cycle? And if we're only getting 8, 10 eggs from you, yeah, you can do it. But that means that you really only have 4 eggs that you're devoting to trying to make embryos in, and another 4 that you're freezing in hopes that in the future they'll make embryos. And those odds just aren't good in either direction. Like we want to at least achieve something, whether it's freezing 10 eggs or using 10 eggs to get to embryos, when statistically we're going to need most of those 10 eggs to get you a good embryo. We want to achieve something. And so what I typically tell people is like, okay, let's start with embryos. Let's see what we get. Because if we get a ton of embryos, then we might feel a little bit better about doing another egg freezing cycle before we transfer one of those embryos. If we don't get any embryos, then we may want to recalibrate what we're doing and how we're going to get there so that your desires are met. Because at the end of the day, the whole point of this is, can we build you the family you want? And having eggs frozen that aren't going to be sufficient to get you that family doesn't do anybody any good.
Well, and I think as a general rule, people tend to be, not that it's not good to be optimistic, but kind of everybody that goes through sort of expects that their embryos are going to be the ones that are going to do great. And that's good to be optimistic. But as a general rule, at least in our practice, we say, if you were a woman who did not have eggs and needed eggs from a donor, we usually recommend that you purchase at least 6 eggs in order to have a pretty good chance of having one genetically normal embryo at the end of it. If you wanted more than that, if you wanted 2 or 3 children, we may recommend that you purchase, 8 or 10 eggs to give you the best chance of having more than one embryo. So from that, you can see even in a young woman who's our egg donor, that's what happens with young women's eggs when they're put with sperm. So if you're beyond the age of 35, those numbers are even lower. So I agree with Carrie. I mean, it really is difficult to split and do partial fertilization and partial freezing if you don't have that many eggs to start with.
So one thing I want to kind of explain to our listeners is that when we're talking about fresh eggs versus cryopreserved or frozen eggs, that it does take a few more cryopreserved eggs to yield an embryo as compared to fresh eggs. So when you're doing all this complex math in your head, realize that those are not completely equal processes. Now, when we actually have a chromosomally normal embryo, whether it's created from a cryopreserved or a fresh egg, those embryos are equal in quality. And so kind of you have 2 different pathways. The end result is the same, but you need a few more on the cryo side as you would need on the fresh side.
And keep in mind when you're pulling donor eggs, because a lot of people will hear from this, oh, they're telling me I only need 6 frozen eggs in order to get the end objective. Donors are deliberately screened to have a higher statistical likelihood of success. So a donor at age 25 can be very different than the patient who's sitting in front of you, with age, with respect to fertility statistics, all of those things. And so most of us tend to go higher in the number that we need because the end result is getting you what you want. And whenever I'm freezing eggs, I assume that when she comes back to use them, she will be 46 years old. Her eggs will be dusty. I will not have any good options for getting her own eggs out. So I always treat it like this is the only shot I get, because a lot of the times this is the only shot I get. And so we tend to go a little higher, but those higher numbers are based in reality, experience, and research.
Well, and let me just say too, the bottom line is all bets are off. I mean, there is no way none of us here have a crystal ball and can look in our crystal ball and say, these are the number of eggs you need to have this many embryos. We're just sort of taking knowledge from different areas. And like Carrie and Susan have both said, these are different. It's in some ways comparing apples to oranges when we're trying to make these assessments. So don't draw a line in the sand and tell your doctor, I need to freeze this many eggs because this is what's going to happen. All bets are off. You never know. You never know how people are going to do, and you never know how their eggs are going to fall.
So one thing to kind of throw a wrench into it is that sometimes, and people and couples come from many different backgrounds, have different, things that create, their belief systems, what they're comfortable with and what they're not comfortable with. And one of those things you have to think about is, are you comfortable having embryos that you may or may not want to use in the future? Okay. And so if you're somebody who, you have to, those are risks and benefits that only the two of you or you yourself can weigh. We are there to provide that information. But if you know in your heart that you don't want to have a certain number, beyond a certain number, and having remaining embryos is going to cause you more long-term emotional complexities, that you may be a person that freezing eggs for that reason may be a better option.
Another practical point of consideration is that not all relationships are forever. Some relationships are only for a season. And if the season of the relationship is not the same season as when you decide to have children, that brings in other complexities. Particularly, so if you are married, it has the potential to be considered joint marital property. And I'm not an attorney, and I don't even pretend to be, not even on TV.
But I think Carrie, in another life, you were an attorney, or you will be an attorney, one of the two. She likes that stuff.
You're still young. There may be a JD in your future.
Yeah.
I remember at age like 6, 7, 8, 9, whenever someone would ask me, what do you want to be? I want to be a lawyer. And I had no idea what it meant, but
there you go.
So that is it, particularly if there's a contractual relationship and you are married to your partner, whoever they may be, that means that is community property. And in the season in which you create embryos, presumably you like each other. The season in which you're dividing them up, presumably you don't. And so somebody who is totally reasonable now may not be so reasonable later. And so having contracts and having it really set in stone, these are mine. I get to do with these, because in general, it's the female, component that is susceptible to age far more than the male component. So have that in mind and know, okay, we're just going to deal with this now, so it is not an issue later, because good fences make good neighbors, good contracts make good deals, all of those things.
You sound like an attorney. You really sound like an attorney.
Been there, done that.
So one other thing, which is a little bit morbid on the other end of the spectrum, and unfortunately we faced this a couple of times, like 3 times in the last year I've been in the situation. Sometimes we've had couples that are married that have an embryo that is frozen. And sometimes I've had a couple of couples that were not married that had embryos that were frozen, and one of the partners passed away. And so the very tricky part about that is sometimes when you sign the consent, you say, okay, in the event of something bad like death, I want my partner to have these embryos. But really the trickiest part is, did your partner really want to have a baby that they weren't there to see and to raise? And I think more and more is sort of coming up about that. I think probably our contracts that we have people sign are going to change a little bit in the near future, just because somebody wanted to have a baby, when they were alive, doesn't necessarily mean they want you to have the baby, and maybe you raise it with a different partner. And so I do think that that's something to think about. I think it's something to talk about with your partner, even though it's a morbid conversation. I think it's important to talk about it and get it in writing too, even if it's not part of your contract that you sign at the fertility center.
Absolutely. So another option that sometimes patients have, depending on what their fertility challenge is that sometimes people may freeze eggs or embryos to use in the future. And if you happen to have good eggs and good sperm, enough that you could potentially get pregnant with something short of that, whether that be natural conception or ovulation induction with IUI or whatnot, that sometimes people try to get pregnant with a little less aggressive therapy now, but have those embryos or eggs frozen for the future.
Mm-hmm. And there's something, I don't know if you ladies have seen this, but I swear I have patients who will have years of infertility. They'll go through the IVF cycle and we'll get marginal results. Like we'll get whatever, just enough to be okay. Sometimes the results are amazing. And then they stop, they come off the meds. We've got our embryos frozen. And then they're just waiting to start whatever the next phase is. And then they get pregnant on their own.
Yeah.
Like it's the biggest kick in the pants. Cause like, well, crap, if you could have done that before, why didn't your body help us out and get us that? But I cannot tell you the number of times I've seen that in various phases where someone, like, they come sit in my office after years of infertility and we do whatever it is we do. Sometimes it's just the stupid consultation. And then they call back with a positive pregnancy test. And I have seen that so many times, and I hear that so many ways from different physicians, that there's something about the priming of the body with
and what
IVF.
Carrie's saying is it does happen, but this is another of those exceptions. It is not the rule. Okay. It sticks out in our brains because we do it so often. This is not what happens, but it does happen.
Because it's unusual.
It does happen. I mean, it's just like the person who comes in for, their new patient appointment, and I go to do the ultrasound, put the ultrasound in, and I'm like, we've got a little fluid collection. There's a reason why you're late for your period. So, any other thoughts or ideas today?
I think the key word for today is planning. Just make sure, just like you plan for your financial future and you plan for your career, plan for family, because I think over the years as women, we've not really been taught to do that. And in fact, some ways people almost make you feel selfish if you plan to do that. And that's not the way it should be. You have every right to plan for your future and for your future family. So I think it's really key to really include that in part of the other planning that you do for your career and for your financial future.
I always tell people, if you are considering enough to come in and see me, or in this case, if you are considering enough to be listening to this podcast, for the love of all that is holy, take whatever steps you need to get the family you want, because it's important. It's a huge part of life, and people feel very unfulfilled when they don't have it, and they can be very unhappy when they don't have it. So let us help you get there, so that even if you totally change your mind, it's fine. But let us help you be prepared so that you A, can get what you want, or B, even if you don't get what you want, it's not because you didn't try, because that sits very different emotionally than someone who just let the time go by and didn't do anything, versus someone who did their best. Like, that person is a little bit better able to move on and live with themselves. And so that's huge. And so think about those things. If you were listening to this episode, this means that this is important to you, and
at least make an appointment
into your decisions.
Yeah, at least make an appointment and come in and talk about it.
Yes.
Yeah.
Well said. Well said. Well, to our audience, thank you so much for listening, and be sure to tune in next week for more. Also, be sure to subscribe and leave us a review on Apple Podcasts. We'd love to hear from you. We are also on Instagram, Facebook, and YouTube, so make sure to follow and subscribe and stay updated on all things fertility.
You can also visit us on fertilitydocs.uncensored.com to submit specific questions. All questions will be answered on the podcast for the Ask the Doc segments. We'd love to hear your episode ideas. So let us know what you want to hear.
As always, this podcast is intended for entertainment and is not a substitute for medical advice from your own physician. All right, we'll talk to you soon. Bye.
Bye.